on strike. Now, this comes as an ongoing doctors' strike entered the 12th day Monday. Doctors all over the country through their union KMPDU have held their position to continue with the ongoing strike. Now, through a phone interview, the Deputy Secretary General of the Doctors' Union, Dr. Dennis Miskela, said they will officially start peaceful protests every week in all the 47 counties. The doctors have directed blame to the Cabinet Secretary for Health, Susan Akumicha, saying she is not doing her work as required.
That this week, from tomorrow, we are also starting our county-based mandamanos. We have Kisumu coming up. We have Meru coming up tomorrow. We have Nakuru coming up also Wednesday. We have Kakamega also coming up on Wednesday for Western Kenya. We are planning one for Coast. And then Thursday, we have a doctors' assembly in Nairobi. The demonstrations is just to put pressure. You know, in these issues, you have to pressure governance, you have to pressure government, and we urge Kenyans to join us in these demonstrations because that's what's suffering. The discussion around the minimum service agreement, which the court had ordered, that we can agree on a minimum service we can offer before we continue our strike. That thing collapsed because you cannot expect us to give a minimum service when you have not told us what is a normal service, what is a maximum service. So for us, we will tell her that let us stop playing politics with the lives of Kenyans. Let us stop playing politics with professionals. If Nakumicha just stop campaigning in Trans Nzoia for governorship and start in the office and focus on working, these problems would not be here. She's the one who did not defend the budget for the interns and for training. And then the teacher removed this because it looked as an priority area. It is a mistake.
Right, just from that story now, I want us to have an interview in studio. I am joined by Dr. Kireki Omanwa. He is the president of Kenya Obstetrical and Gynecological Society. Good to see you back.
Thank you very much for inviting me to the studio.
Right, I think this is a very timely conversation. Just maybe let me get your thoughts on what we've seen there. Now, the clinical officers will be joining the strike. It's already day 12 for the doctors. What are your thoughts on that?
First of all, I think Kenya, we are at a crossroads, if I can say that. I think it is a catastrophe that we are seeing which is unfolding before us. It is not right, it is not fair, it is absolutely illogical for doctors to go on strike because when doctors go on strike, lives unfortunately are lost. And there is nothing that is as important as life. So I think it is a tragedy that we have come back here. 7 years ago, there was a strike as well, which took, I think, about 100 days or slightly more than 100 days. Yeah. It took a lot of back and forth between the union and the government to come to an agreement, the CBA, which was signed, and there was a court order so that the government was supposed to implement it, but that has not, unfortunately, that has not happened. And because of that, we are back here. And we can see the genesis of the strike. Number one, we have our colleagues, interns. An intern is a doctor who has gone through 6 years of medical school and 6 years of rigorous, work in order to get to where he or she is. And they need this 1 year of internship. And internship basically means that they are now getting a hands-on of what they're supposed to be doing. They rotate through different specialties, through obstetrics and gynecology, pediatrics, internal medicine, anesthesia and surgery, so that now they can actually go out and work on their own. So it is the first step in the professional ladder, as it were. So when we have 3,000 interns who have not started, their internship, and we are told that they don't have to do internship, then I think we are dealing with maybe people who do not understand what it means, to become a doctor. And later on, after doing the internship, what it means to go out there and to go into specialization in order to get a specialized, very specialized cadre of workers who are ready and dedicated to work for this country. So I think we are looking at a tragedy, we are looking at a catastrophe in this country.
It's a different government now compared to 7 years ago. Is it?
Yes and no.
Yes and no. Right?
Yes.
Of course, the president was the deputy president at that particular
right.
time.
That is right.
Then do you think the government is being ignorant to the grievances that the doctors are putting across?
Let me put it this way. First of all, when you look at the ratio, WHO, suggestions about the doctor-patient ratio, we are actually very far from there. Very, very far. Look at the population of Kenya, which is about 54 million Kenyans, and we have about 14,000. Even if we were to say there are 15,000 doctors, you can see that the ratio is actually completely low as compared to what WHO recommends. Actually, somebody put some information the other day that actually even Afghanistan has more doctors than Kenya. So it is the doctor-to-patient ratio is better in Afghanistan than in Kenya. And look at what has been happening in Afghanistan for decades. There's been war and so on, but it seems they're doing better than. So what is this that we are not doing properly in this country? And we've had peace for 60 years or more than 60 years. Look at, we keep on comparing ourselves. In the 60s, we're in the same league with Singapore, in the same league with South Korea, and so on. These countries have moved on. South Korea has a population of about 51 million, and it has doctors. The number of doctors is about 140,000. Wow. So when you compare that to us, we are still very, very far in the bush, as it were. We really need to sit down and have a proper conversation and see where our investments go. Something that I would like to highlight on here, when we talk about development and we talk about first world and developing countries and so on, one of the indicators of development is actually maternal mortality rates. Right. How many women die out of every 100,000 who deliver? And in Kenya, we are not doing well. It's a very, very sad story. According to the government statistics, our maternal mortality rates are about 355. So out of every 100,000 women who deliver, 355 will die. So if we say that there are 1 million deliveries in this country in a year, let's say, so we are losing about almost 3,600 women. Yeah. So when you break it down into numbers, that is about 360 women every month. Oof. And that is a number which is out of this sphere. Yeah. Now, when you break it down again into weeks, we lose about 9-10 women every day. So by the time today ends, we'll have lost about 9-10 women. So are we saying that the 3,000 doctors who are interns cannot go to help sort out these issues? Yeah. I think we have a problem. We have a very, very big problem. And maybe to put the whole problem into perspective, you say the clinical officers are downing their tools. Yeah. And I think it was last week when the nurses also said they are going to go on a go-slow. Yeah. This is a potential big catastrophe for the health of everybody in this country. And from where I sit, especially for our mothers. So what we are going to see is that our maternal mortality rates are going to hit the roof, and they are going even to blow the roof. That is number one. Number two, the babies who are going to be born in this period, unfortunately, will bear the consequences, will bear the brunt of this lack of involvement by the government. You will have babies who are born with the neurological problems, babies who will have cerebral palsy, babies with other defects and so on, simply because government doesn't want to come and sit and talk with the doctors. I think that is unfair. It's a dereliction of duty.
With the way you're speaking, even with the numbers that you've given, we're already seeing danger ahead.
Absolutely.
So then what needs to be done? What do you think is the first step that should be taken?
I think the first thing is that we have, let me put it this way, we have court orders which we don't like obeying. So if we obey the court orders, it's very simple. Yeah. There was a CBA which was signed, there was a court order. let's just obey the court order. That is number one. Number two, interns being posted is actually a legal provision. It is in CAP 253, which regulates doctors and what they do, and it is part of the progression from university now transitioning into professional work, and it is part of the process. So let us put this in place. Number three, we talk about remuneration. We keep on hearing about the Hippocratic Oath and so on. Every cadre in this country, I don't know about journalists, but I know you also have an oath of sorts, an ethical, code of conduct and so on. So the doctors have the Hippocratic Oath. I'm sure the judges, the magistrates, the lawyers have their own oath, and so on and so forth. So why are we being singled out that doctors, it is a calling? By the way, nobody called, I never got any phone call from anybody that come and be a doctor. Right. This was a conscious decision, and I've dedicated my life in helping humanity, and all my colleagues are the same. So when you slash the salaries of interns, what we saw the SRC is trying to do, and saying that interns are supposed to earn, I think, 47,000 shillings. So we wonder, 47,000 shillings is it for rent, or is it for transport, or is it for what? And remember, these usually are the young Kenyans who are starting to have families, they need to take their children to school, and so on. They are actually workers, they are not students. And changing a salary to a stipend, I think that is also not correct. Sure. It is absolutely wrong. And then when the CS comes on board and says that she has a number of interns who are ready to work for free, then you wonder why you're introducing slavery into the system, because that contravenes the Kenyan laws of labor, it contravenes international treaties that Kenya has signed to, and so on. So I think we need to really sit down and crystallize where we need to go, and by using conventional methods and things which are in place.
Let's get down to specifics. The gynecologist.
Yes.
Do we have enough gynecologists in the country?
Absolutely not.
Why is that the case?
Absolutely not. Number one, for the record, we have about 600, maybe 700 consultant obstetricians and gynecologists in this country. If you were to divide it roughly and say, because gynecologists deal with mothers, ladies and ladies' problems, starting from teenagers, when they get pregnant, all the way to the menopause, and in between the deliveries and any other, issues where gynecological cancers, infertility, and so on and so forth. The number is actually a drop in the ocean. Because if you look at it this way, if you say the Kenyan population is about 54 million, and if you were to divide it roughly and say half of that population, these are children, and they have not yet reached that stage of reproduction and so on. So we have about 27 million if we work with a population of 54 million. So, and if we say roughly that the 27 million that we have, half of them are men and half of them are women. So we have about 13.5 women. Right. In the reproductive period. So 13.5 million divided by 600. That gives you about one gynecologist to about 12,000 women. Is that enough? Absolutely not. Absolutely not. That is one. Number two, as I said, our membership is about 600, going to about 700. Most of our members are around the big cities, big towns, Nairobi, Mombasa, Eldoret, Kisumu, and so on. Unfortunately, it's very sad for me to say here that there are counties where we don't have. We have maybe one or maybe two consultant obstetrician and gynecologists. So how are two colleagues supposed to take care of all the complications that come from a county? It is not possible. Absolutely. So when somebody speaks that with confidence, I think it's from a point of view of lack of statistics and lack of knowledge.
What's interesting is I think one of the counties that has issues when it comes to maternal health care is like the areas in northeastern, like Mandera, for instance. The maternal death is very high.
Yes.
These counties definitely have governors and they have senators.
Yes.
Do you think the counties are doing anything with this regard?
It's difficult for me to speak on behalf of the counties, but what I can say, I can only say from the point of view of the society. I have 2 colleagues in Wajir, and they tell me, Daktari, we are only 2 of us in the whole of Wajir. Look at the expanse of Wajir, and you only have 2. Even if you are to work 25 hours a day, you cannot be able to help all these women. Yeah. So I think there is it's an urgent requirement and even an urgent plea to these counties to try and train as many consultants as possible, because then when you look at maternal mortality rates and what actually drives these maternal mortality rates, number 1 is human resource. Human resource. In any organization, I think human resource is the most important, because you may have the hospitals, you may have the equipment, you may have the medications, you may have the ICUs and so on, but so long as you don't have qualified human resource, all this basically is useless, as it were. So I think we need to train more. So when we say that we have enough gynecologists, I think that is absolutely missing the point.
I want us to talk about reproductive rights.
Yes.
Do you think in this country there's enough education or awareness when it comes to reproductive rights, especially for women?
That is a very interesting question, because when you talk about sexual reproductive rights, it's a very wide sort of area. But coming back to your question, is that do women do they have access to enough information such that they are in a position of making clear decisions about their reproductive, system and so on? To some extent, yes, we have done quite a bit of work, but we still have a lot of work to do. For example, we have a lot of issues with contraception. There are some societies where contraception is frowned upon. Right. You can't talk about contraception. And here we are not stopping ladies from not having children. What we're saying is that it's a method. There are methods which can be used for them to space these children. You have as many children as you want, but space them such that you'll be able to have healthy children, you'll be able to bond with these children properly, and so on. We talk about issues of, for example, maternal mortality rates. People do not know what maternal mortality rates are and what are the reasons of maternal mortality rates. One of the biggest reasons is what we call PPH, that is postpartum hemorrhage, where women, of course, when a woman delivers, she will lose some blood, 100 milliliters, 200 milliliters. But when you talk about maternal mortality rates, PPH, is where there is excessive bleeding after delivery. It's one of the biggest killers in this country. Do we talk about it? We are trying as a society to do that, and we are trying to do advocacy about what PPH is, and there are plans also to actually make this sort of a nationwide agenda, as it were. We talk about abortion, for example. Right. That is one of the reasons of actually maternal mortality rates, where ladies go and have abortions illegally, and this end up becoming very complicated. Unfortunately, sometimes they end up losing their lives. Right. We have issues of obstructed labor, where what we call bad cultural practices of female genital mutilation, where a woman has, because of culture, has her genitals, completely removed, and when they come to deliver, they have a lot of problems. They end up not delivering, or when they do deliver, they have other complications. Fistula, for example, where they lose urine, they lose stools, stool, in an unnatural way. So yes, we are trying to talk about this. The government is on cue. We are working with other stakeholders as well in this area, but I think we still have a lot of work to do, such that every woman, every lady has the independence of saying, this is what I want to do with my life, this is what I want to do with my body, this is what I would like to do with my reproductive system, because it is coming from me, not coming from outside. Right,
well said, well said. Let's move away from the rights and maybe talk about menopause.
Yes.
How does a woman know she's gotten to menopause? I know there are certain signs and symptoms. I even heard a case before of a 21-year-old getting to menopause at the age of 21. Is that possible?
Unfortunately, it is possible, but we don't call it menopause straight away, because when you talk about menopause, we assume that this lady started the natural process. You know, after delivery, she had her periods. Then she had normal periods. Maybe she did have the number of children that she wanted to deliver, and then the natural process kicks in around the late 40s. The periods started becoming erratic and irregular, and around the 50s, you know, there are no periods. When you talk about that example that you mentioned, a young lady of 21, I have had patients who are 16, 17, 18-year-olds, unfortunately, who manifested symptoms similar to menopause. Right. But when that happens before 40 years, we call that premature ovarian insufficiency or premature ovarian failure, where the ovaries stop doing what they're supposed to be doing at a very early age. And unfortunately, they will manifest symptoms similar to the ones in menopause. First of all, the periods will not be there. They may start having mood swings. They may start having palpitations, you know, hot flashes, and so on. Again, you asked about advocacy. This is something else which many women do not know about. We do not talk about much about it because, for example, there's a couple in a relationship, and then when the lady reaches that age where you know, she starts manifesting these problems, we talked about mood swings. We may be talking nicely with the family, with the children, and with the husband, and then she flips all of a sudden. You know, she's irritable and starts shouting and quarreling until the family wonders, Allah, what happened?
Really?
We were talking nicely, and then what happened?
Wow.
And then you see what happens for us men. We say, hiyo ni mambo ya kina mama, mambo ya wanawake, wachana na yeye, you know, that sort of thing. Not knowing that actually this is the natural process which has come in. And then there are also other issues as well. The lack of sleep, insomnia is also one of the things. The problems I mentioned, hot flashes, mood swings. There are issues with urinary tract infections, which are very, very often, skin dryness, and then the issue of intercourse becomes a problem. And so on and so forth. But there are ways that we can remedy this. There are things that we can use in order for these ladies to transit slowly into that phase of their life, such that it is not heavy on them and it's not heavy on the family and surroundings as well.
I want us to go back to that point you mentioned about the 16, 17-year-olds.
Yes.
You said pre-ovarian.
Premature ovarian.
Premature ovarian, yes. I don't know if you've talked about the causes exactly of that. And does that mean that that lady will not be able to give birth?
Starting with your last question, unfortunately, yes. Yes and no. Let me put it that way. Okay. Yes, in the sense that she will not be able to have her own eggs, or rather use her own eggs in order to have a child or a baby. But do we have technologies where we can help them? Yes, we can. She can use donor eggs, and that is possible. So she can actually be fulfilled as a mother by somebody else donating eggs for her. Okay. But her own eggs, it will be a challenge because the ovarian, what you call the ovarian reserve, the number of eggs in the ovaries is very, very low and may not be able to actually be used in the process of her getting her genetic, not biological, genetic baby, as it were. Now, the causes are different. Sometimes we talk about you may have, if there has been she's ever had any surgery, for example, because if she had a growth or growths on the ovaries, and when we go in to remove these growths, we may remove the growth plus excessive ovarian tissue, and we end up rendering her, you know, in this position of having premature ovarian failure. So surgery is a problem. Chemotherapy, unfortunately. If we use chemotherapy in this young, not only in young, generally when women are in this reproductive period, we will kill the cells which actually produce the eggs. So we render them into this situation. Some diseases, for example, serious infections, can also affect the ovaries and reduce the number of eggs. Some of these women are actually born like that. They are chromosomal issues, and some things run in families, because when you ask them, when you take their history, they will say, I have an auntie, for example, who also has a similar problem, or in my mother's side there was a problem like that, and so on. So sometimes trauma as well can also lead to that. If there is trauma, and then we have to remove the ovaries because of, they have been affected, they have been injured, they have been, there is no way they can remain behind. So that is also a reason. So there are quite a number of reasons which can lead to that.
Wow, that sounds pretty serious, to be honest.
It is.
I'm just curious then, as a society.
Yes.
Do you, or even try to offer, counseling services, or do you try to talk to, especially when it's young girls that age, do you talk to therapists or people to at least give them some counseling?
Yes, because our role as clinicians, as consultants, is once we have made the diagnosis, of course, we try and break it down. That we think this is where the problem is, and we think this is the genesis of this problem, and how can we deal with it such that these young ladies or these ladies have a normal life, as it were. So we work in what you call multidisciplinary teams, where once I have made that diagnosis, of course there are some psychological aspects which I may not be well equipped to deal with. So we involve psychologists, counselors, such that we work together, such that it's a holistic approach and treatment for these patients.
Okay, as we wrap up the interview now, what would you like to see in the country in terms of gynecologists?
My dream is that from where I sit as the president of the Kenyan Obstetrical and Gynecology Society, my dream is that we have enough personnel whereby any patient, it doesn't matter whether it is in Wajir, Mandera, Homa Bay, wherever it is, will have quality care. That is basic. Quality care, not only quality care of such that the same kind of quality care that a patient would have in a good hospital in Nairobi should be the same quality of care that a patient in those places that I mentioned should be able to have. That is my dream. And then number two, that we reduce the maternal mortality rates, because when a mother dies, a cycle of poverty, unfortunately, is activated, which unfortunately, and this is documented, which unfortunately goes even to the third, even the fourth generation when a mother dies. And when we talk about 355 mothers dying, I think there is so much poverty which is being activated every year. That is number two. And number three, I would like, from my point of view, that our colleagues who are starting into the profession, that they may be given the tools that they may advance in their profession. Of course, we would like most of them to come into obstetrics and gynecology, but not all of them may be willing to do that. And then, of course, there's the issue of remuneration and training, such that whoever wants to train in this specialty, and there are also what we call subspecialties as well, that we may have the tools, the tools are there. Basically, we have the program and so on, that we may have peace, that we may be able to train as many of our colleagues as possible, because we'll not be here forever. Other people will come and take over, and we want this quality of care to continue. And then lastly, what I would love to see is that the government is a signatory to the Abuja Declaration, whereby every country which signed to this declared that they would get at least 15% of the GDP going into the health sector. If we did that, I think we would, and so long as this money is ring-fenced nicely, I think we would do a lot in our sphere. And then lastly, maybe the last one, if you allow me. I wish that everybody, and here I want to underline everybody, would actually go for health services in public hospitals.
Okay.
Because then what that would mean is that you don't have an option, whether you are a senior government official or senior parastatal official, you have to go for these services in a public health hospital. What that would mean is that more resources would flow into the public health system, and that would have a knock-on effect on the quality and availability, accessibility, and so on. But so long as we have a two-tier system whereby, as a senior official, wherever it is, I have access to private, or even to going abroad for services, then unfortunately we will not make a lot of progress in terms of making our public health system better.
Yeah, that's a dream, like you said.
It's a dream, but just like our compatriot says, our dreams are valid.
Our dreams are valid. Thank you so much, Dr. Kireki. I think this has been very enlightening conversation. Thank you so much for your time.
You're welcome. Thank you so much.
That is Dr. Kireki Omanwe. He is the president of Kenya Obstetrical and Gynecological Society in Kenya. Right, I want us to take a short commercial break here on News Center. We'll be back with more stories. Stay with us.